9:59, but it says 9:57 on my phone. So I let people in now so the participants can come in and we can get settled. All right. Oh, great. Welcome in. I see lots of people joining, so thank you. We're just getting set up and we'll give a few more minutes to let you all filter in, and a warm welcome. Thanks for joining us this morning. Okay, we're going to go live on Facebook as well. This is so exciting. Okay. Okay, welcome in. We have lots of people joining from different areas, I imagine, and welcome. So if you've joined us before, this is part 2 of a 2-part series. So we had Connie a few weeks ago doing part 1, which is up on our YouTube channel, and it's also on our website as well. Kind of more information, and she'll do a little bit of review of what she covered before, but then we'll go into a little bit further focus on advance directives this morning. So welcome. Thank you, Connie, for being back. There is such a positive review, and just deep thanks for sharing your knowledge. So thanks for coming again.
You're so welcome.
I'll get you to slide forward, and we'll do a little introduction of who we are. So Family Caregivers of British Columbia. And we're a nonprofit, 100% nonprofit, that is dedicated to the well-being of family caregivers. We have been in service for 30 years now, and we are a provincial organization. In the past 5 years, we are with the Ministry of Health's Patients as Partners initiative. And so we have 3 pillars that we offer, which is caregiver support. We have a toll-free care support line that is open from Monday to Friday, 8:30 a.m. to 7 p.m. And they offer support to caregivers, referrals, and navigation of the healthcare system. We have support groups that are offered weekly, and caregiver coaching as well, that's offered all virtually right now. But the second pillar, education, and that's kind of where the webinars fall into, and any additional resources that we have online. We have a podcast that we recently launched. We have tip sheets, articles, blogs, and also Facebook Lives that we have once or twice a month that we've been offering. Specifically, it's really gotten good traction during COVID. And we have our newsletter, our e-news, and lots of great material that goes out with the hopes that it will support you as you're navigating your caregiving role. And then our third pillar is also engagement and collaboration with other disease-based organizations, but also with our healthcare professionals. So educating them on caregivers and how important they for our healthcare system. So thank you. That's who we are. And then also just a little review of our webinar today. So everyone will remain muted and your cameras are off for the duration of the webinar. And you can see kind of on the bottom, there's a Q&A, polls, and chat. We won't use the poll today, but we'll, any questions that you have, you can type in the Q&A and I'll be monitoring that. I'm Kate, I didn't even introduce myself. I'm Kate with Family Caregivers, and I'll be going through that. And then also there's a chat box as well that you can use if you'd like to chat with other people that are here today or just comment. There will be time at the end for Q&A, and we'll pause during the duration of the webinar as well. I also want to just take a moment to acknowledge and thank the Lekwungen people, also known as the Songhees and Esquimalt First Nations community. I'm on their lands today in Victoria, and allowing us to live and work and play on this beautiful land. So taking a moment to acknowledge the land that you're on and giving thanks. And that will lead me to our thanks and our introduction to Connie.
Thank you. Somebody had just said that there's a lot of echo. Is there a lot of echo on my line? Because I'm going to be the one who's speaking the most.
I am good with hearing. It might have been on my end, but okay. You are sounding clear to me. I'm going to introduce you, Connie, because I have a great, can you hear me okay?
Yes.
Okay, so Connie, our guest speaker and presenter this morning, is the founder of Patients Pathway, a senior healthcare navigator and patient advocate. She holds an International Professional Advocate Board Certificate. She is the National Advanced Care Planning Coordinator for Dying with Dignity Canada, and she has also published her first book, Healthcare 101, a guide to navigating the Canadian healthcare system, which she will share with you today. She was also an RN for 25 years and has been an advocate first and foremost for her patients. We're so excited to have her expertise and her knowledge presenting this morning. So what you can expect from our webinar today, there's going to be a review of the part one, so you can start to understand if you weren't here last time. Strategies to develop your own advanced care plan. You're going to have a chance to consider your own values and beliefs that inform your planning and where you are on your health journey. Discussion and considerations for choosing your substitute decision maker, and a review of types of representative agreements and writing. And now over to you, Connie.
Thank you. So, Family Caregivers of British Columbia and I are very much on the same page in empowering patients and those who love them by gaining knowledge and having an assertive voice. You have a much better chance of getting the healthcare you need in a very complex, fragmented, and siloed healthcare system. The healthcare system is very, will readily agree that they are siloed and fragmented. So that means that one area doesn't talk to the other. They don't really know what the other people do. And so I'm helping you today to get over some of those hurdles so you get the information that you need. Sorry for just a second. That wasn't a COVID cough. So this is my book, Advanced Care Planning. It's the first one in Canada that talks about the entire advanced care planning journey, but the first half is on how to navigate the healthcare system, and it's broken down into clear sections on how you can get the healthcare that you need. And I highly recommend it for all adults of all ages. because serious and complex illness, injury, and life-ending diagnosis can and do happen to anyone of any age. So the bulk of my clients are certainly in their later years, their senior years, but I also have a lot of clients who are in their 20s, 30s, and 40s who have had life challenging issues. I'm just going to pop over here and see. And so we don't really think about that when we're in our 20s, 30s, and 40s. But it's more important than at any other age, really, to be thinking about this, because there are huge financial and socioeconomic issues that arise when somebody who's younger becomes seriously ill. In my book, there are detailed indexes and resources. Read what you can, what you need, and when you need them. And then put it in your in case of emergency folder and use it as your guide when you or your loved ones are in the healthcare system. And then use it as your healthcare Bible. If you do get my book, it's kind of overwhelming. If you're not already in the system, you can't possibly remember it all. But when you need it, you suddenly need it. So I highly recommend it for yourself and your loved ones. So advanced care planning is important for all adults, no matter your age of your state or your state of health. It's only starting to get recognition that this is not end-of-life planning. This is planning that should start when you're in your 20s and just going out on your own. It involves estate planning as well, and I'm going to go over that. The COVID-19 pandemic heightens the need and the urgency for which we should all complete our own advanced care planning, because it always seems too early until it's too late. The earlier we begin these discussions, the more easily they take place. If they take place when you're well and otherwise healthy, then there's no worries in the family saying, why are you telling us now? Why are we having this conversation now? If you have it when they're younger, it's kind of like sex education. When you start with kids when they're really little and let them know about their bodies, then they're not as resistant to having that conversation with you as you get older. And the same should be happening with your adult children and grandchildren. A lot of people who are in the advanced care planning world actually give their loved ones something like my book, or pay for them to go to a lawyer to have a representation agreement done, those kinds of things, so that it becomes a conversation that happens early. Caregivers, which are you, often neglect their own advanced care planning. I have done now hundreds and hundreds of workshops, and it's mainly women who are looking after their parents. So the caregivers are already in their 40s, 50s, 60s, sometimes 70s, still looking after their parents. And they come up to me afterwards and they say, I guess I should get this done for me too. So they were there for, to gather information for their parents and realize that they should be doing it. So are you looking after you? Advanced care planning is not one document. It is an umbrella of documents and conversations about your values, beliefs, and preferences for future healthcare for a time when you cannot make your own decisions. It's a vital topic for family caregivers who are reluctant to bring up these conversations with those that they care for. This is a really tough one, especially if you're in your 40s, 50s, or 60s. Often our parents grew up in a generation where you just didn't talk about your health. You didn't talk about your death. And we are in a death-adverse society where we're highly anxious about talking about dying. We just want to have it done. We all want to die when we're in our sleep, when we're 93 years old without any other health issues. And very few people actually die that way. And so it's really important that we have gentle but important talks, and hopefully I'll give you a few indications for that. In my book, I give a lot more ideas on how to begin those conversations, and I know that they're tough. And don't think, and so it's also important for caregivers who don't think it's important to do this planning for themselves. So this is the Advanced Care Planning document or umbrella. Values and beliefs are front and foremost. They are the most important thing that you can do for yourself. There are ongoing discussions, because without ongoing discussions, everything else you do is useless. Putting your health documents together in a way that's easy to get that information across to your caregivers or to your future healthcare teams, but it's also to organize your own healthcare documents and put together your representation agreement and, if possible, advance directive. There's a really important piece that people forget about or don't want to face, and that's financial documents, and I'm going to go over that briefly. And then there's estate planning, which is wills and naming your executor and getting life insurance, those kinds of things. So advanced care planning documentation is done in a preparation for a time when you are no longer capable. It is not for a time when you can still speak for yourself. And when you cannot make your own healthcare decisions. During COVID-19, this is extremely relevant. With COVID-19, the progression of the illness can be sudden, and even prior to ventilation, you may be so ill that you can't make decisions and will need to rely on others. If you are on a ventilator, you will likely be deeply sedated and others will need to make decisions for you. And a lot of people are really considering whether they want to be on a ventilator or not. Our health, long-term care, our residential care system seems to be doing a very good job of providing palliative care in place so that patients or their residents are dying in the long-term care facilities rather than going to hospital and needing to be on ventilators where the chances of survival are extremely low. For yourself and for those you care for, the process is considering your own values and beliefs of your loved one as well as your own. The shocking statistic that I found was that 70% of spouses don't know what their spouse would want at the end of life. They've never had those discussions, and without those discussions, spouses often make decisions based on what they want rather than what their spouse would want. Determine where you are in your healthcare journey. This is an incredibly important assessment. With COVID-19, we know that those over 65 are much higher risk of developing symptoms, serious symptoms, serious progression of the disease. And choose your substitute decision makers. That can be done formally or informally, and I'm going to talk about that in a moment. And the biggest thing of all is to talk to your substitute decision makers and loved ones and document your wishes. So I'm going to go over what a substitute decision maker is. So there are strategies in completing your advanced care planning. What I'm going to go over today is a little bit overwhelming. And so it's important to prioritize what needs to be done. If something unexpected was to happen to you tomorrow, such as COVID-19, what would you need to have done? What are the biggest risks to you and the person you are caring for? Do this part of your advanced care planning first. For some people, they have all their paperwork in order. They already have their representation agreement. They've already done their estate planning. Their taxes are done. So you might just need to put everything in a place where somebody else can find all that paperwork. But for others, and for most of us, the biggest thing is having conversations with our loved ones. So this is a time to have those conversations, and I'm going to give you a couple of hints on how to do that part. So if you can, set up a buddy system with somebody you know and make yourselves accountable. So this month we're going to get this done. Next month we're going to get this done. It would be better if it was this week and next week, but set yourself some goals. Make sure that this stays at the top of your priority list, because there are a lot of people who come to my workshops and they will have attended last year and then they come back and they go, I haven't gotten it done yet, and I just need to refresh myself on what needs to be done. So use today as an impetus to move forward with your documentation. You can change or cancel any of your advanced care planning documents at any time. When a person is capable, they can be changed or canceled, and legally that word is revoked at any time. Often, with advanced care planning documents, you will just simply write at the top of your new document, this advanced directive revokes any previous advanced directives. So I'm just going to stop there. Kate, can you tell me if there were any questions that came in regarding the beginning of this?
I can, yeah. I'm just responding to a few. Basically, just a big thank you to your book, that people have purchased it and found it very useful. There was one question just asking where to find your book, and I know that you'll get into that, but I also shared the link on Amazon, I hope that's okay, of where they could purchase it. Yeah, if you want to add anything to that.
Okay, so it's on Indigo, Indigo's website, Amazon, and Self-Counsel Press. So if you just type in Connie Jorsvik, Advanced Care Planning, in your web search, where the book is available will come up, but I've got links at the bottom, and so we'll take it from there.
That's great.
Okay.
And we'll tomorrow you'll get an email as well with any of our resources, and I'll add in your book links, Connie.
Thank you. Okay. Whoops. So step one is to think about your values and beliefs and preferences for future healthcare. Have these vital discussions now prior to the possibility of serious illness. As I said, it's way easier for you to be able to say, there's absolutely nothing wrong right now. Just want to have this conversation with you just in case. And I like to turn the little bit of what's the word I'm looking for? When we feel like if we do something like this, it is going to cause an illness, or we are going to have something serious happen to us. I like to think about it in the reverse way of a superstition. That's the word I was looking for. If I take my umbrella on a cloudy day, that for me says that it's not going to rain. So you can just, if you've got an underlying value or a superstition about doing these kinds of things because it's going to cause it to happen, just kind of think, well, I'm doing this, that means it's not going to happen. We are all going to get old. We are all going to die. And it's really, really tough to think about that. But once you've thought about it, once you've gotten all of this stuff done and had these conversations, the vast majority of people will go, phew, just so glad it's done. And then you can put it aside. You've had these conversations, you've done all this paperwork, and it's just one more thing that's just done. So decision makers need to know the wishes of those you care for in order to assertively speak for them. So it's your mother, your father, your husband, your adult child who needs you to make decisions for them. You need to know what they want. In this webinar, Focus on Values and Beliefs is a short exercise focused on a time of crisis. I've got a lot more information in the book about values and beliefs and some in-depth homework on how you can do them. I apologize that in the book, everything is very small to fit on a page, so you might need your reading glasses. So what makes life worth living for you? What can or cannot be sacrificed or compromised? What needs to be completed before you die? And consider any special faith-based or cultural preferences. So what makes life worth living? I'm going to go into this a little bit more, but is it time in your garden? Is it time with friends? Is it meals with people that you love? Is it time spent reading a book, having special music? I was laughing about this with a friend of mine because I can't go a day without talking about this stuff. And I said, you know what? If somebody had puts on classical music when I am at the end of my life, I will come back from the other side and whack them on the head. And so I have actually made a special Spotify playlist that I would want towards the end of my life. I could listen to it over and over and over again. So it's those kinds of things. You know, if you had a special book that you would want somebody to read to you, what are those values and beliefs that you hold dear? And what can or cannot be compromised? So that means that if you want to die at home, that might mean that you don't have a treatment where you might die in hospital, or and I'll bring that up in a couple minutes. What do you or your loved ones value? And so that kind of goes in with beliefs. How do you feel about quality of life versus quantity? And this one is really big. So for most of us, we would want quality of life versus quantity, whereas we would want to have time with our families, to be able to have conversations, to be able to say goodbye, to say all the things that we want, rather than be drugged up and virtually maybe in pain. But family members want quantity versus quality. So they want one more day with you. They want one more dance. They want one more meal with you. And so they are willing to have health treatments done that will give them that one more time. So that's where the conflict arises, and that's where you need to be very clear with those you love about quality versus quantity. And where do you or they want to spend their last hours or days of life? Home or hospice or residential care? This brings up a story of mine when I was a cardiac nurse, and I was with the doctor, the cardiac surgeon, when he went in to talk to this 86-year-old man who said, "You don't have a choice, Mr. Smith. If you don't have cardiac bypass surgery, you will die." And the patient went along with the surgery. And I wished that he'd had these conversations about values and beliefs, and had this conversation not only with his loved ones, but also with his surgeon, because he didn't do well after surgery, and he ended up dying in the hospital 6 months later. He never left. He never went home. But if he had chosen to not have surgery, he might have died quite quickly at home in his easy boy chair or his recliner, watching his favorite TV shows, maybe having a few more conversations with his loved ones, having meals at home. So there always is a choice, and that's where values and beliefs and preferences for future healthcare come in. The healthcare system tends to come in and do everything possible to find out what's wrong, how to get you better. They're there to make you better. You have to decide whether you want to have those invasive procedures or not. So step 2 is determine where you are in your healthcare journey. This is incredibly important. Consider values and beliefs in a realistic context of your health and age. Think about what's important in yours and their life now and in the future in case of serious injury, illness, and end of life. And I'm going to stop there to see if there were any questions at that point.
Nothing on my end here, Connie.
Okay, so choosing your substitute decision makers is a quick review from last week. The substitute decision maker, we call that person the SDM, is the accepted worldwide term for the person who will make healthcare decisions for you when you are not capable of making decisions for yourself. If your loved one is not able to make decisions on their own behalf and they have not assigned a substitute decision maker, a temporary substitute decision maker, TDSM, I keep on forgetting to change that slide, will be authorized to make decisions for them. This is not always the person who is looking after them at home. If they want you to speak for them, strongly consider a representation agreement. So I've seen this play over and over and over again, where the adults, the two parents, are going down the same dementia road together. So both of them have got some cognitive issues, or one has cognitive issues and the other one has physical issues. Under the temporary substitute decision maker hierarchy, the spouse comes first, and then the adult children, all equally ranked after that. And I'm going to go over this in a minute. And then adults, then siblings after that, also equally ranked. Sometimes there's conflict, but the biggest thing that I've seen here is when the two spouses have their own issues and the other spouse really should not or would not want to make these decisions. When my dad was seriously ill, in and out of hospital, my mother assigned me as the substitute decision maker. At that point, there were not representation agreements. She assigned me as a substitute decision maker so that she could just be there and hold his hand. She didn't want to be asking all those questions of the hospital system. But without assigning me as substitute decision maker, all the information legally went to her, and it was overwhelming for her, and she couldn't often relay that. Even though my mom was completely cognitively intact, she was overwhelmed by everything that was going on, and she relied on me to be that person to get all that information. In British Columbia, a substitute decision maker is formally and legally named on a representation agreement. This is probably the most underused, undervalued document in British Columbia. We are the only province in Canada that has something that's formally, where the person is formally named on a document. In the rest of the province, it can be an enduring power of attorney for health, or often just written on the Advance Directive. This is a very powerful legal document that we should all be really proud that we have. It gives you the exact same legal rights as the person that you are representing. So a special note about memory. If memory issues are becoming apparent, it's imperative to make decisions regarding a representation and enduring power of attorney documentation as soon as possible. If you don't do this quickly, there can be a lot of issues that arise. A lot of people, as they go down a dementia journey, become paranoid as things go along, and they think that they're capable of making their own decisions. And so it's best to get this done early and to have these conversations before that kind of concern about you're taking away my power are starting to take place. None of us want to be parented. All of us want to remain the adult in the situation. And if we start having these discussions early and say to your aging parent or your aging spouse, it's really, I care deeply for you and I want to take care of you as best I can. So it's really important that I have this agreement in place. If somebody has begun to go down the dementia road, it's really important to have these conversations as early as possible, and that is where I recommend that you bring in a lawyer. You can do a representation agreement 9 without a lawyer, but I highly recommend a representation agreement 7, which is for diminished capacity, be done when with a lawyer.
I'm just going to pause you, Connie, because I had someone ask, and I think you just answered it, but someone had asked, what is the difference between an enduring power of attorney and a representative agreement? So I just want to make sure that that person got her answer.
Right. And I will talk about that, and it's so, so important because in the healthcare system, there is a complete lack of understanding. Fraser Health Authority is doing an incredible job of teaching their healthcare teams about advanced care planning. It is lacking in all the other healthcare authorities to some degree. And so a lot of people believe that enduring power of attorney is for both health and finances, and it's not. A representation agreement is for health, care, and personal, and I'm going to go into that in a minute. An enduring power of attorney is only for financial. And enduring means that it's in place when the person is both capable and incapable. So it doesn't have to say in the title, this is an enduring power of attorney, as long as somewhere in the document it says this is in place when the person is both capable and incapable. And I'm going to go over that a little bit more. The biggest one is mental capability. And I've searched high and low. I've had multiple conversations about mental capability. And whoops, I forgot to change that slide too. So I'm just going to go forward for a second. No, I didn't. So mental capability is very fuzzy. When a person is in a coma, when they are unconscious, when they are clearly in advanced dementia, then it's fairly clear. But when somebody is receiving a lot of medications that makes their thinking capabilities a little bit less than it should be, if somebody is in moderate dementia, as long as they can say what they want, they are still considered capable. It is very, very difficult to have somebody deemed incapable unless it's clear. It can only be done by a doctor, a trained social worker, and for legal purposes, a lawyer. Somebody from the public guardian and trustee can have that discussion. And I've had a lot of times where that grayness on where that person is on the capability scale is definitely in question. So somebody can say, yes, I want to go home from the hospital, but they don't understand all the things that would have to be in place for them to go home. And so the healthcare system pushes for that person to go home. Well, Bob said that he wanted to go home, so we're going to make it happen. And especially now, we've got a lot more push during COVID to get people home as soon as possible. There's not a lot of home care in place. So it's really important that you have these conversations about, can I step in, Dad, and say what you can and cannot do, what you are capable of, if the hospital is pushing for you to go home. That's the major thing that I'm involved with, is early discharge and inappropriate discharges. And often that capability is in question. So a few things to consider when you're choosing your representative. You can't be paid to care for them except for a spouse or adult child. So you can make provisions to pay your adult child in particular to come and care for you and take time off of work. But it can't be a paid caregiver from a care facility. It can't be your doctor. If you've hired me, it can't be me. You must be a mentally capable adult, and that can be fuzzy. You are readily available, or it shouldn't be fuzzy for the person who's going to be a representative. They should be clearly capable of making those decisions. You are readily available even by phone. You are ready and willing to take on the role. You will respect the religious or spiritual beliefs, and you will carry out their wishes even if they are different from your own. I apologize for some of my typos. The representative is often a close relative, so they can also be a close friend or a neighbor. So one of my clients was Bob, and he was an 86-year-old bachelor who was struggling to be on his own. And he had a niece and nephew who were far away in the province, who couldn't get to him readily and were often unavailable by phone. So he chose his neighbor, Nancy, to be his representative, and Nancy was then able to receive all the information from the doctors, be available, and then she would transmit that information to the niece and nephew, and they made joint decisions about next steps. Expect a little backlash from the hospital system if it's a friend or a neighbor, but sometimes you actually have to highlight on the representation agreement that it can be anybody that you choose. Talk with your representative and loved ones, share your values, beliefs, and preferences for future healthcare wishes, and don't assume they will know what you want. So I'm going to go into the two types of representation agreements so we're a little bit more clear on them. The one that is rarely used, I've used a representation agreement 7 probably about 5 times in the last 8 years, is a representation agreement 7. I call it the light version. It may be signed by someone who does not meet the traditional definition of capability. They may still be able to name a person they trust to manage their health, personal, and it can include financial management of their affairs. And that is a very decreased version of financial affairs. So they can pay your rent, they can pay your bills, but they cannot get into your bank account, they can't transfer funds. And banks are really reluctant to have this kind of agreement. In a couple people who I'm representative for, I've had to go into the bank. We've had to explain it at length. They're just, because banks are national by and large, so Van City and the other BC credit unions have more experience with this kind of representation agreement. And so back to that, and the representation agreement 7 doesn't allow a person to make end-of-life wishes or choices such as stopping the ventilator or withdrawing care. And it does not allow a person to make decisions about where that person will go, such as long-term care and home care decisions. So it's a really light version, and it's meant to make sure that the person, that the adult that you're caring for is not being taken advantage of. So representation agreement 9 is what most adults will want. It does not allow for financial management, so an enduring power of attorney should be considered if you want to appoint someone to manage the financial affairs. A representative 9 is authorized to assist with healthcare. Your representative helps you make healthcare decisions, including end-of-life care decisions, or speak on your behalf when you are unable. They are allowed to collect your mail, water your plants, clean out your fridge, take care of your pets, and all those kinds of things. And they can make decisions about future living arrangements, such as assisted living or long-term care. So this is everything that you as an adult would be able to do, your representative can do. And when you're in hospital, sometimes you're capable of making your own decisions, but you're just too muddled. And you can say to the healthcare team, Bonnie is my representative. I want her to have all the information that I have. Right now, my daughter is my representative. My son is my alternate. I don't want them knowing about every single thing that's going on with my health at this point. They can only step in when I ask them to step in. So there are several documents, and this is what the question was about. There's an enduring power of attorney, there's the representative, there's an executor, and often not needed is the guardian and public trustee. You may name one or more people for several roles, but separate documents are required. But lawyers tend to put these documents together, so they will put the enduring power of attorney together with the representation agreement and closely link that with the will. But it does need to be, they need to be laid out separately, and the person is, one person can do 4 roles, or you can have 3 people. I'm not including the guardian and trustee. One person does 3 roles, or 3 people each do a role. So step 4 is talking with your substitute decision makers, and I'm including representatives in this. Conversations with your loved ones and substitute decision makers are the most valuable part of advanced care planning. Without having the conversations, a representation agreement is absolutely useless. I have had this conversation with so many lawyers because they do a representation agreement. They have not explained fully what it is for, and it ends up going into their files and nobody knows that it exists. People don't know that they're the representative, or it was discussed with them briefly and they don't know what it's for. My concern is on a Friday or Saturday night when the lawyers' offices are closed and somebody ends up in emergency. So it's really, really important that you have these conversations and that your document is available. These conversations aren't easy, but so try and keep it simple, direct, and specific. The most simple, direct, and specific was a client of mine named Henry. He was 86 years old. He was in extremely frail health. He needed to have a valve in his heart replaced. He couldn't have open heart surgery. So they were doing a special procedure where a heart valve was being put in through his groin and into his heart, and it was being inflated. He knew that it was really risky. He was either going to walk out the next day with a new heart valve, or he was probably not going to make it. And he didn't do well. Before he went into surgery, we sat in the cafeteria, and on a piece of paper he wrote, "If I cannot be out in my garden, if I cannot have my grandchildren on my lap, if I can't walk out of this hospital on my own steam, I don't want to live." So when he didn't do well after the surgery, his family used those criteria as to whether or not to let the doctors keep on working on Henry. And when it was very clear that he would never make it out of the hospital, they said, "That's enough. That's all that we should do." And Henry actually died on his own about an hour later. But it gave them so much relief. They had a really clear direction on where he wanted to go, or what he wanted his life to look like. For Henry's family, it was the biggest gift that they could give. He could give them. It brought them so much relief. There was a lot less complex grief. So it can be the biggest gift that you give to your family, is to have those conversations. And then documenting your preferences for future healthcare. Step 5 is Advance Directives. Every province has a different name and healthcare legislation stating your values, beliefs, and preferences for future healthcare. The universally recognized term is an Advance Directive. In BC, it is called an Advance Directive. You still might find a lawyer or a notary, but particularly notaries are still prone to put together a living will or maybe a letter of wishes. Those are awesome. They are great. And in fact, I think that some ways they are better than an advance directive. They are not legally binding. So it puts down your preferences for future healthcare. It writes down your values and beliefs and what you want and don't want to happen. But it doesn't necessarily hand tie your healthcare team to what has been said, because we don't have crystal balls. We cannot know what the future lies. And there's a lot of research to show that when we are younger, we cannot imagine lying in a bed in the living room and having our family around us is a good quality of life. But as we get older and as we become more frail, that's what we want. We want our family around us, and it can be the most joyous time of life. So it's really tough to paint yourself into a really tight corner when you're younger, not necessarily knowing what you'll want when you're older. If you write a legally binding advance directive, remember that it can be changed all the time, and it should be. So I don't recommend that you go to a lawyer and have your advance directive put as part of your representation agreement. Keep it a separate document that you can change over and over and over again as your health changes. So as I said, they're called something else. They can be called a living will, a basic advanced care plan, a personal directive. If it is not signed and dated and witnessed by two people, it will be considered, but is not a legally enforceable document. And so during this pandemic, if you have not identified a substitute decision maker, or they may not be immediately available to speak to a healthcare professional, your advance directive should be as clear and detailed as possible. And I recommend that all documents are put on your fridge, and I'm going to go over that in a few minutes. On your advance directive, healthcare clinicians need to know who is going to speak for you if you no longer have the capacity to speak for yourself. So that's where you can name your substitute decision makers if you have not written a representation agreement. Specific medical treatments you do and do not want to have, such as CPR, intubation, and ventilation. I really recommend that people don't use the vague terms of no heroics. It's just too fuzzy. And I'm going to go into that in a minute. Your values and beliefs. So you might be a 76-year-old who looks completely healthy on the outside, and paramedics come and you have written that you don't want CPR. They may question that because they don't know the context, but they may not know that you have an underlying condition that you don't want your life extended beyond that time, that it's important to you that you have a dignified death, or that you're willing for things to come to an end. So it's really important that you put your values and beliefs in context of what you do and don't want in your healthcare, that it is signed, witnessed, and dated. Representative discussions and decisions take precedence over advance directives. This one is not necessarily true in law, but it is what it takes place at the bedside. So if you have written, I have a couple people who've written in their advance directives that their advance directive supersedes their representation agreement. In other words, they don't want there to be any question from their representative what they do and do not want. But a lot of the time, our representative has more information at the front lines, at the bedside, than you had taken into consideration in your advance directive. So for instance, it is the 23rd of December and you are actively dying, but you would have not have wanted to die on or before Christmas because it is an anniversary then becomes cemented in your loved ones' lives. Or you want to wait for a certain relative to come, or you want to hold your grandchild in your arms for the first time. You might want extra care. You might want blood products or antibiotics or extra oxygen or what is ever needed to get you through that hump. And so that's where the representative can say, that is not what Aunt Mary meant when she said that. She would want to be alive to hold her grandchild for the first time. Okay, I went through that one already. But representatives are legally obligated to honor your wishes or what they believe you would want if you had been able to speak for yourself. Does that matter? Whether you've written in an advance directive or not, representatives are supposed to honor what you would have wanted and not what they would want for you. So who can write an advance directive? You can. If it meets the legal requirements and is properly witnessed, it is valid. And if you are just writing a letter of wishes and you don't necessarily want or need witnesses, you just want to put down on paper what you want, then you can just sign and date it yourself and you don't need to have witnesses. Strongly consider discussing the most appropriate level of care with your physicians or your nurse practitioners. So now I'm going to be heading into what's called medical orders for scope of treatment. This should be based on where you are in your life and your health. So I've based the following examples of advance directives on medical levels and orders, which are similar across North America, even though they are called many different things. In British Columbia, most of British Columbia calls them medical orders for scope of treatment, and everybody calls them most. If you happen to be in the catchment area for one of the Providence healthcare authorities, that includes St. Paul's, St. Joseph's, Holy Family, and a number of hospices, they call it options for care. These are orders that are signed by a doctor or a nurse practitioner, and usually in a hospital, after consulting with you or your substitute decision makers about the level of resuscitation you want. They are also being presented, I think, quite inappropriately at residential care units. It's something that's handed to families, and I am vehemently opposed to that. They are medical orders that you shouldn't be under the responsibility to interpret and sign by yourself. It should be discussed with you by a doctor. So if you happen to have the medical orders for scope of treatment handed to you, please ask to have a discussion with the doctor. Discussions and decisions for Advance Directive should be made prior to a crisis, so you can do that on your own. But medical orders are often written during a hospitalization or crisis. In the community, if you have a life-threatening or life-ending diagnosis and you are receiving palliative care or hospice, your GP or the hospice palliative care team should have these discussions with you about medical orders for scope of treatment. But both your Advance Directive and your MOST should be hand in hand. So there shouldn't be a big conflict between what you would want on your Advance Directive and what is signed on your MOST orders. So write your Advance Directive, and again, for simplicity, I've actually used MOST orders and the levels of care to be consistent with what you are going to be presented with in hospital, residential care, or in palliative care. So think about what you would want to receive. I've broken it down into 5 options from most intensive to least intensive. The focus at each level is where you are in your health journey and on your values and beliefs. Use this as a guide when talking to your loved ones and representatives and writing your Advance Directive. I also highly encourage you to talk to your doctor, your family doctor, or your specialists such as cardiologist or your kidney doctors, whoever is looking after the end-of-life care, and to make sure what you've chosen is appropriate. The highest level of care is perform all resuscitation, including CPR, which is cardiopulmonary resuscitation. It includes chest compressions, intubation, ventilation, and defibrillation. If your heart is restarted, you will go to ICU and you will likely be on a ventilator. So I've seen some Advance Directives where it says only do CPR if it looks like I will make a full recovery. That's impossible to decide. No paramedic, no first responder is going to go, I wonder if Mary is going to make it. No, I don't think so, so I'm not going to start CPR. It just doesn't happen. If you've said CPR, you get the whole 9 yards. But if you do not want to be resuscitated at home or in the community, you must have a signed medical order in British Columbia that says no CPR. It's signed by you and your doctor, and you must have that form with you at all times, or you have a special medical alert bracelet on. So if you go to HealthLink BC and you type in no CPR, this form will come up and it will go through all the directions on how to get a medical alert bracelet as well. This is for, so no CPR or no resuscitation, no CPR, but put me on a ventilator, is for those who are relatively healthy and want full resuscitation. Sorry, just wish I could back up. No CPR, or all resuscitation and CPR is for people who are relatively healthy and want full resuscitation. Everything will be done to save your life. Level 4 is down just a little bit, and this is often where people who anticipate that they might have COVID, or that they're concerned about COVID, but they don't want CPR, but they would want everything else done. This is do not perform CPR and allow other forms of resuscitation and transfer to critical care. This is for those who may want the option of admission to ICU or a critical care unit and want or need all medical care, including being on a ventilator, but do not want CPR. You may still want or need extra vigilance and care after a serious injury, illness, or surgery. So sometimes patients who would otherwise not want to be have heroics, such as CPR or ventilator, are having surgery, and the doctor has advised them that you might need to be in ICU or CCU for an extra couple of days just to have more nursing care and to have your vital signs monitored more closely. And so this is the level you would be at. But please note that you can also, you can choose this level of care, but you can also stipulate treatments you do not want done, such as ventilator or dialysis. An important note that when you say something like, I don't want heroics, it means you don't want CPR and you don't want a ventilator. A ventilator is considered life support. So level 3 is where a lot, I would say the majority of older adults fall. So don't be too concerned about those previous 2 levels. This is where medical treatment without transferring to critical care do not perform CPR, such as chest compressions or any resuscitation. Symptom management may involve transport to hospital for a higher level of care. So I've got a client who has advanced liver disease. She has cancer and she needs to go periodically to have the fluid in her abdomen drained. She is on a progression for the end of life, but she doesn't want to suffer. She needs to go to hospital for this particular treatment. And this being at this level of care allows her to go back and forth to hospital and have things that would otherwise be the end of her life be treated. Another couple of things are people who have anemia and need to have blood transfusions now and again, or people who are just not drinking enough fluids and need extra hydration, or maybe you need to have antibiotics for a bladder infection or a lung infection such as pneumonia. This is a really important level of care if you want to be admitted to hospital. So even if you are in long-term care, residential care, assisted living, and you're getting older and towards the end of life, you still likely want to be at this level so that you are going to receive all the care that is deemed appropriate. This is meant for those who have significant health issues or frailty. Because this is conservative treatment, it does not include the use of a ventilator, but can include the option for non-invasive respiratory support such as CPAP or BiPAP. You've seen that now on the news where the people have the tubes into their mouths or they have a big mask over their face and it's providing positive pressure. So that's considered a non-invasive respiratory support. And it's important, especially if somebody has COVID and you don't want them to just die of lack of oxygen. So CPAP or BiPAP are really good options. Before I go on to level 2, I want to make a distinction about CPR and do not resuscitate. So no CPR and do not resuscitate are the same thing. In British Columbia, we use the term no CPR officially, but everybody uses the term, I'm a DNR, she's a DNR. It means that that person is not going to be resuscitated. So I just want to make sure that everybody's really clear that no CPR and DNR, or do not resuscitate, are exactly the same thing. So when you're approaching the end of your life, you're in residential care and the doctors have said, she's not going to come back from this. This is a pneumonia that is going to take her life, or she's just, she's just slipping away from us. This is often where the representative and substitute decision makers are stepping in and saying, we want mom to be here. And so this is, do not perform CPR, chest compressions, or any resuscitation, symptom management and supportive care only. So the person still might be getting antibiotics. They still might be getting oxygen. They still might be being fed. Those are all options under this level, but we know that we're not going to do anything heroic to save their lives. So they're not going to be sent back to hospital for IV antibiotics. They're not going to be sent back to hospital for anything that is going to further their lives. This is meant for people who have multiple health issues or frailty, who are nearing the end of their lives. It's often the appropriate level for those in residential care or receiving palliative care who are nearing the end of their life. The goal is conservative management of medical conditions with specific short-term symptom-directed treatment. It may allow medications such as oral antibiotics to be given. And level 5, again, comes down to the substitute decision makers or the representative, because often at this point, the adult is no longer capable of making this decision. This is end of life. Do not perform CPR or chest compressions or resuscitation. Symptom management only. The person may not be eating or drinking at this point. You're not going to be giving any medications that they can no longer swallow. You're not going to be putting in an intravenous, and you're not going to be tube feeding. This is for those who are at the natural end of their life, who have a life-limiting disease and no longer want treatment, but want to maximize comfort and symptom control at the end of their lives. Just a little note about oxygen at this stage. Oxygen is not considered to be life prolonging. It is just provides comfort, and often it's given to provide comfort for the family and those who are there, rather than the patient themselves. If the patient is gasping for air, oxygen will be provided, because none of us want to die feeling like we're suffocating. And I'll talk briefly about this stopping eating and drinking. It is a normal, natural thing for somebody at the end of their lives for their bodies just to not want to eat or drink anymore. It's difficult for families to watch that happen, but it is not a painful thing for the adult who's dying. Once they have refused food, once they can no longer safely take food or drink, it's often a very fast way for the end to come, and it apparently causes no suffering for the person who is dying. So there's a checklist for advanced care planning, and then I'll get to questions. So you've done your advanced care planning. Please don't think that you haven't done your advanced care planning if you haven't checked every one of these boxes off. This is just a checklist for when you've done it all. And when you've done it all, you should be reviewing it. So it's always a path in progress. You've chosen your future substitute decision makers, whether that is informally or formally, thought about your values and beliefs, decided on your preferences for future healthcare, discussed your values, wishes, and beliefs and preferences for future healthcare with your substitute decision makers. And that line can go up or down. Sometimes you need to talk to your loved ones about your values and beliefs before you put any documentation in place. You've completed your Advance Directive and had it signed and witnessed, or you can do your informal letter of wishes now. And I did that when I was first starting my own plan, is that I just kept on changing and adding to my letter of wishes. As more information came to me, I would just tear up the old one and put the new one on the fridge, and I would sign and date it, and that at least gives some direction to loved ones and to your future healthcare team. You've completed or reviewed your power of attorney for finance and indicated where it can be found. So do not put your enduring power of attorney or your will or any other sensitive documents on your fridge in a pouch. Just tell your loved ones or those people responsible where it can be found, and reviewed your will and indicated where it can be found. Put copies of all relevant documents in a clear folder, binder, or green sleeve, and place those documents on or beside your fridge, or put a clear note on your fridge indicating where these documents can be found. So a lot of people don't want to put this on their fridge. They've got friends. Well, right now we don't have friends coming and going, but we do during other times, or our fridges are made of stainless steel and it doesn't fit. The universal place to put that is on your fridge. Give copies of important documents to your substitute decision makers, to your enduring power of attorney, and to your executor. And if your directive is specifically in preparation for COVID-19 and it is different than it would be in other circumstances, consider revoking or rewriting your directive after this crisis has passed, and let's hope that that's sooner rather than later. And a couple additional notes. I've got an in case of emergency form on my website. It is free, downloadable, and fillable online, and then you can change it as often as you wish. and a few additional hints of things to think about. Do you have someone else in your home that will need care? Clearly indicate that, and who first responders should call. So if you've got somebody who has special needs or somebody who is has dementia, often caregivers go down first, and it's really important that you put things in place for your loved one to be taken care of. Otherwise, both people will end up in hospital. I've seen that so many times. Make pre-arrangements for your pets and have those clearly indicated on your documents. Some people have it on the front door. I've made pre-arrangements with the SPCA and where to call. And really important is let someone know where all your relevant account and computer passwords are. This can cause so much pain and anguish for families. So I've got a little book that I keep them all in, and it's in a hidden spot, but my loved ones know where it is. Leave a legacy and not a mess. This is an opportunity to review and put in place your paperwork for advanced care planning, financial preparation, and estate planning. Financial planners and notaries and lawyers are still working, although like the rest of us, remotely via telephone and teleconference. All the notaries and lawyers who I've talked to have said that they're busier than ever because people are doing this work. So that's really good. And now it's a time for questions.
Wonderful. Thank you, Connie. I've been holding some of the questions because I feel like some of the things that you did say probably did answer a fair amount of the questions. And I also just want to acknowledge, I know we're just past 11, so if you do need to leave, I just want to thank you for coming. There was so much good information here. It is a recording that will go up on our website, and you'll be sent the link with additional information that Connie has provided. So if you do need to go on with your day, I just want to say thank you. So we have a question about, sorry, losing it now. Oh, there it is. Once you fill out the representative agreement, where do you need to bring it to for it to become legal?
It is legal the moment that you sign it. In British Columbia, we do not have a repository or a registration site. So nidus.ca, Nidus is the best organization in the world regarding representation agreements. They have what they call a registry. It's really a repository for all your documents. It costs $25 for the first document and $10 for every document after that. It's a really good place to put things just so that that your loved ones, the people who you've assigned, can go there, because not all people have got the best filing systems in the world. And so you've given them a representation agreement, but then in a time of crisis, they can't find it. So it's really important that it go there. If you've had it done by a lawyer, they should be keeping a copy. I always recommend that that you keep your representation agreement in a filing cabinet or in your safety deposit box, but you have a copy that's available and on your fridge. I've seen representation agreements go several times. The originals go to hospital with people, and then they are made part of the chart and they disappear. And it's really hard to get those back from health records. So if somebody in the hospital wants to see the original, you can bring them the original, but never leave the original with them. So in summarizing, a representation agreement is a legal document as soon as it is signed and witnessed. You don't even have to have your representative sign it for it to be a legal document, though it's a really good idea for your representatives to sign it, because then they actually know that they're your representative.
Mm-hmm. That's great. Okay, another question. If I do not have an RA9 that you talked about, is my spouse automatically my rep?
They're automatically your substitute decision maker. So there can be issues with that. And I'm seeing a lot of issues with that right now during COVID. Some hospitals, depending on whether they've had an outbreak, such as Delta, where they are completely shut down. There are no visitors coming or going. At the moment, St. Paul's VGH most hospitals where there are some active outbreaks in the community are severely restricting visitors, but they're not restricting representatives from having those conversations. So I would highly recommend that even for spouses, you do have a representation agreement done. A substitute decision maker does not have as much legal authority. And so one of the things that always comes up for me is when health records are required, if you want to get the hospital records or any kind of health records, if you are not the representative, even if you are the spouse, you cannot get those without the adult's permission. So a representation agreement takes 5 minutes. I really hope that even for those who are spouses or adult children, that you will take the time to go to nidus.ca, where they have the best forms, to have that done literally in 5 minutes. It takes another 5 minutes to have them witnessed and signed, and it's done. And so I don't want time to be an excuse for you. Everybody should have a representation agreement, whether they're a spouse or not.
I think you just answered the next question I had here. The documents available online, you had a PDF NIDUS also. And I think you also did this, or you went through this, it was around most, but is a medical order for scope of treatment the same as an advance directive? And why would you need a most and an advance directive?
Yeah, and that's a bit of a tricky one. A most means that a doctor's actually sat down and talked to you about it. Unfortunately, I see the most being written during a time of extreme crisis. And I've seen it done when literally the person's heart is stopped and the doctor has run out and asked the family to sign the most, saying no CPR. So an advance directive is the gold standard. A really well-written advance directive is a gold standard. What I see is a lot of advance directives are not easily interpretable by the healthcare teams for a time of crisis. So if you have put down one of the things that I've written there about what level of care you are at the top of your advance directive, that's going to make it really clear for your healthcare team. But if you've written something really vague, such as no heroics, then it's just too vague and doctors don't know how to use it. One other thing I want to say about advance directives and most is that some health authorities are doing an incredible job with the most orders. Fraser Health is doing an incredible job with them. Interior Health is pretty good. Vancouver Coastal Health should have their wrists slapped. They're just doing a terrible job regarding it. So you really should have an advanced directive that will be paired with the medical orders of treatment or scope of treatment so that they can be used together. If you have an advanced directive that's clear, most is not needed. But if you don't have an advanced directive, then most should be discussed with you. So it's this fluid thing, but if you're starting to have those discussions and you know that your loved ones can have those discussions with your doctors, you are 90% of the way there.
Okay, I'm getting lots of questions, so it might be helpful to, I don't know if there's another form too that people can specifically talk to you. I'll ask one more. So do I understand that I, the representative, may override the most level indication by the loved one if they are the level 4 and has been taken into hospital?
If the adult signed it, no, you cannot override it. That means that you are doing something that the adult didn't want done.
Right.
So you have to, as the representative, you are legally obligated to go along with their wishes. However, if you've got information that says something like, Bob would have liked to hold his grandchild in his arms one more time, then none of this is so set in stone that they're not going to listen to you about that. So overriding, maybe having a conversation. So when you have, doctors are not terribly good at these things. The one person who I would always ask for is the social worker. If you're in a situation like that, ask for the social worker. They are well trained. They know everything about advanced care planning, and they are the people who are supposed to be those people who will help you with those kinds of decisions. Nothing is cut and dry in the medical system unless you've written down that you do not want to be resuscitated. Then after that, everything is a lot more fluid because we don't know what we don't know until we get there.
Okay, I'll ask one more. I just put in for that person that was asking specifically about the NIDIS website. I just typed it in for you. A question about parents having signed documents for their doctors for a do not resuscitate order. This person's on the chart as an alternative contact. Is this enough? Which I feel like you've probably touched on, but.
Do not resuscitate in British Columbia legally must have a no CPR signed by the physician and by the adult or the representative if the person is no longer capable of making that decision for themselves. So where does that come into place? That comes into place usually in critical care or an emergency when somebody is unconscious and they know that the person is not going to survive. Or has a very poor chance of survival, then they will have a discussion with a representative and a no CPR or a most orders signed right there.
Connie, do you want to maybe just share where people can reach you, find you for more questions, your book, your services? I think that that would be really beneficial.
Yes, you can go to my website, which is patientpathways.ca. There's a contact us form there, or my email address, and I'm just going to put that in, I think. So I've put my contact information at the bottom of this, and maybe you want to copy that and just put it into, well, this will be on the recording, so people can just pause it here and grab that information. So this is where my book can be found. I would love it if you bought it through Self Counsel Press. It's a local organization, a local publisher, and I see a little bit more and they see a little bit more than on Amazon. So
that's wonderful.
Okay.
And just a reminder, Family Caregivers of BC, our caregiver call line is open weekly. We'll have more webinars offering in November, December, and into the new year. This recording will go up. I just put in the chat box our survey today that to give feedback to our offerings and to hear from you and what might be of interest for future webinars. It will also be in a link that follows tomorrow in your email to fill it as well. But sometimes it's helpful to do it right after the webinar because it's fresh in your mind. So thank you so much. This is a huge topic, and I think it's something that probably needs to be revisited many times. So thank you, Connie, for your time and your expertise. It's been a pleasure working with you. Okay, have a good day, everyone. Thank you for joining, and until we see each other again virtually, take care.
Thank you.
Bye, Connie.